Well, good morning to everyone, and we couldn't be more excited about our panel and the concept of collaboration. As many of you have known, for the last 3 or so decades, we've been very focused on collaboration. And we initially spent almost all of our energy in the area of science, research, basic, translational, and clinical. And over the last decade or so, we've focused far more on the issue of, can we create this collaboration around public health? Can we bring industry, philanthropy, disease-specific organizations, government, schools of public health together and create a collaboration? And that is what this session is about today. New collaborations around health, prevention, wellness. And I thought maybe the best place to start, we have this diversity. Francis Collins, who runs the National Institutes of Health, Lynn Goldman, who runs the School of Public Health over at GW, Bob Hugin, representing biopharma as the executive chairman of Celgene. And so we can look at it from 3 different views. And I thought we could first start our theme of a new world of collaboration from that standpoint. And we're going to start by talking about some successful cross-sector collaborations that they've each been part of, they've witnessed from it. What can we learn from those collaborations, and how can we apply them to public health? And Bob, why don't you start us out with a view there?
Well, there's a couple that immediately come to mind. One, a collaboration between companies and both healthcare providers and payers to find ways that both improves care for our employees and reduces cost over time. And there's some very innovative examples of that, which are critical both for affordability of treatments and medicines, and also ultimately long-term cost prevention. The other one I think I really want to mention is about the promise for the future. We actually engaged University of Pennsylvania, Johns Hopkins, Mount Sinai, and Columbia cancer centers together, and they agreed to work together and share patents, ultimately share royalties if something is discovered. And the logic behind it was to say one of the great engines of American economic growth and public health that Mike talks about in terms of really producing the kind of advances that extend life and improve the quality of life is that competition, that whole ecosystem of biomedical innovation. But we're in such an economic crisis in our country long-term with the aging population, all the things that you know better than anybody else. How do we maintain that spark of just really the drive for invention, but at the same time share the cost and don't have redundancy in the support of things that don't affect directly the invention itself? So this collaboration is an example of trying to find earlier diagnosis of disease, be able to treat it early and find cures for it to prevent the long-term cost of it, but have everybody compete for the invention. But if biostatistics should be done by one university or another because they're either better at it or more available to the access as opposed to rebuilding it someplace else. So reducing the redundancy of cost, but not limiting the competition for invention, and then creating a benefit for everybody called the Cancer Trust. We really invested in it because we wanted to be a template to show we can have collaboration between industry, academic medicine, and academic medicine within itself without losing the benefit of that kind of competitive spirit.
Lynn?
I want to talk a little bit actually about collaboration in the space of preventing antimicrobial resistance. One of the things that I have observed over the years is that there's been a tremendous amount of kind of blame shifting. You know, it's the clinician's fault for overprescribing the antibiotics, it's the patient's fault for demanding the antibiotics, it's the farmer's fault for using too many antibiotics as growth supplement and feed, and none of that was getting us anywhere. And we've begun a process at GW, and I know the CDC is very involved with similar processes of bringing those communities together to jointly take responsibility for stewardship of antibiotics so that we don't lose them. And as a pediatrician, there's hardly anything I can be more passionate about. The idea a child could come in with a bacterial infection and you would be unable to cure that child is one of the scariest things that I think you can confront. What we've been able to do at GW, and I know the CDC as well, many of the farming groups, the chicken industry in particular, they're actually be able to innovate and find ways to stop using antibiotics as a routine additive to the feed, change the ways that they're raising the chickens so they can do that. But also the acute care medical industry, that they also can see that they have a major role in basically not prescribing antibiotics for viruses. They don't work anyway. And when this had been approached just as a regulatory process and one where people could shift the blame, we weren't getting very far. So we're not all the way there. This is a global problem, but I think this is definitely an example of a successful collaboration.
Thank you, Lynn. I think you see this area in so many fields, not just health, if we think about education. So if you're running elementary education school, your issue is what was done with the child and early child care of the parents. They weren't ready at 5 or 6 or 7 years old for school. Middle school principals saying their problem is the elementary school didn't prepare the kids, and obviously high schools stating that the high schools had not prepared the kids, and then colleges, particularly community colleges or state colleges, suggesting that the high schools. And so I think Lynn's issue here is we need to understand the system and everyone's responsibilities in the system. And as we addressed issues of antibiotic resistance yesterday, the general public has so little knowledge of the deployment of pharmaceuticals in the growing of animals for humans to eat, etc., whether it's before conception, whether it's the birth of a chicken, dealing with the egg, etc., and understanding just the volume of antibiotics, etc., that are used in that process. Francis, before I go to you, we had one of the founders of our country, Benjamin Franklin, who gave us this political cartoon, 1754. So quite a while ago, and he was trying to explain to each of these, quote, separate colonies that we needed to join or die, that we have a common mission, a common goal. And you'll notice that when this occurred, it was more than 20 years before 1776. We, Francis, took the liberty of redoing, without royalties, Ben Franklin's comment of, collaboration. And you are there, right there in the middle of this activity. So as you think of these issues, let's step back and think of some collaborations that have worked and where there's a roadmap for the future.
Well, yeah, great cartoon, and yeah, I'm glad that at least in that image we were still connected at FDA, if not to anything else. But we're working on joining up those segments, and let me say an example about that. I do think this is a great moment to talk about collaboration. First of all, science has provided opportunities because of the revolution in basic science understanding about health and disease to bring together the sectors that are now interested in turning that into clinical advances and figuring out which parts of this we can work on together. And for NIH, that's often figuring out which parts are pre-competitive, where our colleagues in the private sector are interested in the same kind of achievements, and we can get together and figure out how to speed that up. An example is the Accelerating Medicines Partnership, AMP, which is now in its 3rd year of pushing the agenda very aggressively to try to understand the next generation of therapeutics and biomarkers for diabetes, for Alzheimer's disease, for rheumatoid arthritis and lupus, and just now added another project on Parkinson's disease. If you go to slide 38, it will tell you another one of these that has just gotten announced in the last 2 weeks, which is a partnership on cancer immunotherapy. And this is 11 companies, including Celgene, thank you, Bob, and 10 others, each of which agreed to put $5 million on the table. NIH came forward with their contributions of $160, so that's $215 million to bring together all of this expertise to try to understand, why does cancer immunotherapy work when it works? And it can be dramatic in melanoma and leukemia and lymphoma. But why does it not work for most solid tumors right now? Pancreatic cancer, brain cancer, in most cases of prostate or breast cancer. We ought to be able to figure out how to get the immune system charged up to go and find those cancers too. But we could probably do it together a lot faster than having everybody off in a corner working alone. Those kinds of opportunities are what I think drive us to see this as an exceptionally good time for linking up those segments of your serpent there. And FDA is a critical part of that. Another part that we need probably to work harder on is to bring the reimbursement effort together with all this, because ultimately, if we're going to succeed in making these advances, they have to be accessible to people. And that's something, particularly for genomics and precision medicine, that we're not quite there yet, and that's going to need some work.
So last night, we had a discussion with Jim Kim, head of the World Bank, and the focus of the World Bank on human capital. This is where the Milken Institute and all of our centers started, this concept that human capital, the productivity of individuals, was the largest asset in the world, and his analysis at the World Bank he presented last evening was it's about 65% of all the assets in the world. Our work has presented as closer to 75%. So how do we increase the value, this asset that's the dominant asset in the world, human capital? One, you extend the length of their life and the quality of their life. And obviously this has been the major driver of the world's economy in the last 200 years, when pretty much everything that's happened in our history has occurred, growth of our population, growth of the economy, etc. So we're going to improve the quality and length of life. An increase of 80% in South Asia and Southeast Asia of life expectancy in just a little more than 2 generations. Second, education, lifelong education, different jobs, different skills. And that is what's focused. So Bob, as you understand, as well as everyone in building your company, the most valuable asset you have are those 7,000 plus employees that work for Celgene. How does Celgene seek to help its 7,000 employees avoid preventable chronic disease?
It's an important question. I think it goes beyond Celgene. One of my biggest issues, I think, with corporate America is that many people talk about their employees being their most important asset, and then out of the other side of their mouth, people say, go do your healthcare yourself. We don't care about it. It's not our responsibility. And I think that's one of the great opportunities when we think about leadership and the change that's needed to kind of produce the kind of early diagnosis, early care to prevent long-term costs. I think corporations can play an important role in that, and it benefits corporations. We've seen very little change in the per capita spending on healthcare for our employees, and we pay almost about 90% of their healthcare costs because we've been engaged with them and have an engaged process where we understand what their needs are, and we try and be proactive both on a number of fronts. We target what employees want. They want the ability to exercise, and we want to make sure they have the environment that they can do that. On the food side of it, we don't want to be paternalistic, and I'm a civil libertarian. I want to give people choices, but on the other hand, we have a responsibility, and we do subsidize the food in our cafeterias, and we make sure that we only subsidize healthy options and limit the other choices as much as we can within reason to create the right kind of environment. And we've seen great success where employees have really gravitated to the kind of food that is more healthy, more information about the food. So we try and understand what they want, provide it, and at the same time we look at our healthcare costs very closely. We see, what is it? What do we do? We had 7 years ago, we had a premature baby or 2 born in the same year, a relatively small population. We put an incredible information education program for partners and our employees to say, here's about prenatal care, and we did a great education. We haven't, knock on wood and coincidence, but we haven't had one since. We think about the weekend warriors, an issue of how people spend their money and not being fit and able to do the things they want to do. So we try and really be engaged with them, and we think it creates great engagement and people want to do better and support the company even better. So we think it's a real win-win economically. More importantly, it's a win-win to engage in people to accomplish the mission that we have as a company to do great things. So I think it's a thing that we have to recognize. I think we have to advocate more forcefully to say corporations have to be bigger leaders on the issues that we're here to talk about in prevention and wellness, and they have a responsibility because we support them in so many other ways with public expenditure, et cetera, and we shouldn't be afraid to expect them. The government has a critical role, but the speed at which change can happen in private businesses to set the standard, to innovate, to experiment, to try things, that cycle can be so much faster, and we should have an increased expectation that it's their responsibility and it's their duty to do it, and it's good for their business to do it.
So, Bob, very simply, doing good is good business?
Absolutely.
Okay, and supporting your employees and creating an environment that supports them in their health.
And smoking, Marty's in the audience, we don't allow people to smoke on our properties anywhere in the world. If everybody did that, we could reduce the burden of the incredible expense we have of caring for the diseases of smoking, which prevent us from putting money in the places that could have much more significant long-term benefit to society.
So, Lynn, let's switch to you. You know, we have presented the concept, and it's changed over time, of where does business leadership come from? And if you look back to the 1970s in America, you will see that many people that were the CFOs rose to become the CEOs of the companies in the 70s and 80s. And it was greatly due to the enormous volatility in financial markets, whether your company could survive, not, and how you finance that company. Today, obviously, the focus on the competition for employees, the keys of making sure they feel they have meaningful lives. So as we start to think about where the leaders of tomorrow in industry might come from, Lynn, we often think about those from public health programs. How do you prepare your students for leadership? Most of them have historically gone and becoming in charge of public health for Philadelphia, New York, or city. How do you prepare them today, your undergrads, grads, and PhD students, for leadership roles in different fields?
Well, first and foremost, I think a very important ingredient in all this is that the students today are very interested in leadership tracks, far, far more than in earlier generations. And if you offer a course with the word leadership in it, you are flooded with registrations for that course. Students are gravitating toward that.
Give us a feel for the size of your School of Public Health. How many grad students do you have at Celgene?
Well, we have a total of about 2,200 students. And of those, most of them are graduate students. We have about 500 undergraduates. Does taking a leadership class make them into leaders? No. And one of the things that we teach them is that, of course, most all of you in the room are leaders. You know, to become a leader, first you have to become very, very good at something, but you also have to have a number of skills that are broad skills around, being able to understand not just what you become good at, say you become good at epidemiology, but you need to understand some things about finance, about management, about working with people, negotiating. Those are skills you need as well. Some of us learn it on the job. I suspect that Francis, like me, was an on-the-job learner for many of those things.
Oh, yeah.
But we can teach those skills, and we are teaching those skills. But the wonderful thing, though, is that we're working with what I'd call very fertile ground, that these students who are going into public health want to lead. And we need to provide them not only with the education, but also the opportunities in terms of internships, ways to build their career, mentoring. All of that is incredibly important. Just as in a business school, you want to do that.
Thanks, Lynn. Francis, the NIH is a global treasure. I think more and more people around the world understand that issue. And breakthroughs, whether they're in basic science, translational science, or even clinical, you have had a preeminent role in that activity. But you've also focused on prevention. Mm-hmm. Talk to us a little bit about the NIH role in prevention and wellness.
Well, I'm glad for the question, because I think oftentimes people have thought about us as the National Institute of Disease, and we certainly have institutes that have disease names, but we really are focusing increasingly on prevention as a strategy for ending up with better outcomes for most people where they don't have to get sick in the first place. How do we approach that? Obviously, we need to identify areas that are predisposing people to a unwell trajectory, and we should probably talk about obesity at some point in this
Well, go
discussion.
ahead. No better time but now, friend.
Goodness sakes, that is still, when you look at the contribution to chronic illness and premature death, a remarkably dangerous path that we are on. It seems some numbers have just appeared here on the screen. How remarkable is that? So, and you can see that we in the U.S. Are leading the world in a way that we don't really, I think, want to be in terms of obesity rates. And while we have seen in some instances perhaps a flattening of what has been a really scary upward trajectory, not nearly enough of that is going on. It's a very complicated issue. And again, research studies that we've done in many ways would indicate that we're not going to tackle this particular problem by just one thing. It's got to be a wide variety of things that relate to better understanding of basic metabolism and molecular biology, but also understanding social contributions, which are really significant in this space. And how do you get communities engaged in solutions? And how do you work with the food industry also to try to make sure that we're not contributing to the problem by the kinds of things that kids are putting in their mouths because they saw them in some kind of advertisement? All of this has got to be done in a fashion that we still have not really pulled together in this country. And we, NIH, we can provide some data about research studies, but this has got to be a major public health initiative if we're going to get anywhere. If I can, I want to sort of lay out, though, a new initiative which is going to get launched in the next few months that I think will provide us with the kind of data gathering for obesity and for lots of other areas of prevention that we currently don't have. So if we could actually pull up slide number 39. Just want to point out that we are at a moment here where we have opportunities to do things that we didn't before. Patients are interested in partnerships, if you can click through this. Basically, we also have in that electronic health records. Although they're clunky, you can use them for research. We have technologies, wearable sensors. We have genomic opportunities, and all of this providing a big data kind of opportunity to gather lots of information on lots of people. That leading then to the slide after this, if you can go to slide 40, to a program called All of Us, which is precision medicine writ large. And by the way, if you're interested in this, if you actually go to a website that is www.joinallofus, all one word, joinallofus.org, you can get yourself on a list to get regular briefings on what's happening with this program, which aims to enroll 1 million Americans in a prospective longitudinal study that will keep track of all manner of things about them. Their health practices, their electronic health records accessible, blood samples that will be used for whole genome sequencing, wearable sensor data keeping track of environmental exposures, all of this on a very diverse group of people across the country, geographically, socioeconomically, ethnically, age and gender, diverse in the way that we haven't often had the opportunity to use in terms of looking at health disparities. We're in beta test right now. We've enrolled about 5,000 people to try the various parts of this in order to see where we are. And in the space of the next few months with that beta test information, we will be ready to do this launch in the spring. And I hope all of you will think about signing up. Mike has already asked me to reserve a place, and I promise I will do that because I want to understand how your health has managed to be so amazingly successful. We need the world to know about that. But this will be then a data set which any qualified researcher has access to. We will protect the privacy and confidentiality of the participants, but this is supposed to be an engine for discovery. And there will be 1 million Americans who are pre-consented for recontact if they want to be involved in some follow-up clinical study. So as an engine, a platform, if you will, for pretty much all the things that you might want to do to follow up, this is going to be there, and that's one of the reasons to do it. And thanks to the 21st Century Cures Bill, this is actually funded for the next 10 years, so we're quite confident in its stability and the opportunity to do this. This, I think everybody might want to track pretty closely as a way of addressing the prevention need and thinking about how we could do a better job of keeping our nation healthy.
So Lynn, before I go to you, I just want to kind of set the stage here. Later today, you'll receive a lot of data, the different programs and new studies that the Milken Institute and others have put out. And when we think of chronic disease, which costs the United States between $3 and $4 trillion a year. Half of it is hard dollars, half of it is soft costs, such as absenteeism, presenteeism, and many other factors. The number one cause of chronic disease is obesity. So as you look at what are the contributors to this issue, and one of the challenges for all of us here has been the relative lack of success of our efforts in this area. And Bill Dietz, who runs the Global Center for Prevention and Wellness, has probably been the world leader in documenting these issues over the past few decades. When I think of myself, for me, I was at Berkeley, I was a sophomore, and they opened a new shrine in Berkeley. No, it was not a new religious establishment, it was something called Top Dog. Okay, and it brought Nathan's hot dogs and these fantastic hot dogs to the West Coast. And I made a promise to myself I would never go to sleep without first stopping at Top Dog from the day it opened while I was going to school. And if I was not feeling that well, I would have 2, and if I was feeling great, I would have 12. Okay. And so to me, like so many others, there's food that they loved. And when we think of Oscar Mayer today and this Wienermobile, I mean this symbol that traveled around, and as a little kid it might come to your town, the Wienermobile. Who couldn't get excited about it? But even Oscar Mayer, Kraft Heinz has changed the hot dog to respond. I had to give up hot dogs when I was diagnosed with cancers because my choice was, what did I like better, living or eating hot dogs? I chose living. Good. But I just want to show you how the Wienermobile still is alive today as they try to bring a new look to a hot dog to deal with it in the 21st century. Lynn, then we'll go to you. So let's look at this very short video.
No.
Oscar Mayer can go to great lengths with their hot dogs and change every single one. Why can't we go to one of the most remote cities in America?
So we're gonna make sure we get there and get a hot dog in every person's hand.
We are headed to Whittier. I know that it's hard to get to, and I know that we're gonna have some challenges ahead of us.
There's just a lot of ice out there.
Kind of just driving on faith here right now.
I'm pretty nervous about that avalanche coming down.
Oh, this is a lot more narrow than I thought it would be. Whittier! We made it!
Look at that.
I saw you guys come down the road like it's the Wienermobile.
And finally be able to bring our hot dogs to the people of Whittier.
They really love when you taste.
No artificial preservatives in our meat, no added nitrates or nitrites in every single one of our hot dogs. Who else has done that? Just Oscar Mayer.
Traveling all over the country for the love of hot dogs.
Okay, so we're not even sure that that hot dog, which I'm not going to eat, even though they've taken the nitrates out, they've now brought it to this remote village that very few people ever visit, that has 200 people. But when Mexico passed a tax on soft drinks, on junk food, the response was to increase advertising. So nothing is really kind of a straight line from that standpoint. And Mexico was really the first country that really moved in this area. And they allowed you to travel free in the subways in Mexico City and the buses if you could do 10 squats. So part of our goal is if we could get Americans just to weigh the same we weighed in 91, we could have a $1.5 to $2 trillion increase to our economy. Lynn, I know this is something you've studied for a long time. What is your view, and why haven't we made more progress, even though, as Francis has told us, we're starting to see a little light at the end of the tunnel? And obviously this is no longer a United States issue because we've exported it to the world. And we see that the incidence of hormone-driven cancers, breast, prostate, et cetera, have increased dramatically in China as they've changed their diet. Lynn?
Well, if you go to slide 15, I mean, we do know that obesity has tripled in the world since 1975. And actually, this is what the average BMI for men was. There's a similar one for women. I'm just going to show you the men. And if you go to the next slide, actually, you can see the increase between 1975, really a tripling, not only that, but astounding 1.9 billion people in the world now who are overweight or obese. And so we have exported many aspects of our lifestyle that are great to the world, but some things that aren't so great, like diet. And I would say even with safer hot dogs, you don't want to eat 12 of them, Mike. But if you go to slide 17, people are not aware of the linkage between obesity and cancer. We're very aware that it's of course a risk for heart disease, for diabetes, a lot of morbidity and mortality, but also cancer. And then in fact, 40% of cancers in the United States have obesity as a risk factor, 55% in men and 24% in women, and partly because of the connection between obesity and breast cancer. And if you look at the next slide, not surprisingly, slide 18, that we can see that these cancers are concentrating in the parts of the country where we have more obesity. And trust me, I could show you other problems that are epidemic in this country that are concentrating in some of these same states. When you talk about the well-being of people in this country and human capital and life expectancy is a measure of that, we are right now seeing for the first time a downturn in life expectancy for many people in this country. And especially people of lower income, people in certain parts of the country where there are not only higher rates of obesity that are responsible for this, but the opiate addiction problem, which I know we're going to talk about later, alcohol-related mortality, and even suicide. And I bless you, Francis, for undertaking this enormous study, because although some of this we understand very well, and we know what we can do to address it, some of it we don't understand very well at all. I personally have had trouble comprehending the fact that one of my own public health students last month died of an opiate overdose. An elite athlete, a brilliant young woman, and had prescriptions. I'm pretty sure I share that with many of you in the audience, that you actually firsthand or secondhand know of somebody who has been personally impacted by this epidemic. And there's a lot of work that we have to do, Francis, to address this.
Can we look at slide 31?
Let me just go to Bob for one second,
sure.
then we'll pull that up. Bob, some of the most exciting breakthroughs coming from biopharma are now looking at prevention and wellness, interventions to help people with obesity, hypertension, et cetera. And so we don't necessarily think of the biopharma industry as focused on the area of prevention and wellness, but more dealing with a person that has a life-threatening disease or a serious disease. Could you give us some insight into that?
Well, I think what's really exciting about it is, and obviously NIH and France's leadership has provided a lot in terms of early detection of disease and how to identify what the precursors of disease are, and it's been helpful. I was in California 2 weeks ago, and I must have met with 15 different companies that are started up today that are just focused on that early detection, that early diagnosis, the ability to intervene very early. And it's incredibly exciting that the technology is finally coming into place when you talk about liquid biopsy, to be able to really predict what's going to happen so early. So I think it's important when we think about the national responsibility to focus research where there's great social need, whether it's Alzheimer's, metabolic disease, and cancer, the diseases of the elderly that are going to undermine the economic fabric of our society if we don't find inventions and cures or delays to the onset of these diseases. And I'm just really pleased to say that I think when you see about the 10, 12% of companies that are being formed today are being formed in the focus on early detection, early diagnosis, that really gives us the best hope for reducing the cost factor. The one thing I wanted to also ask Lynn, when she's talking about obesity, because it's something that I think metabolic disease is critical for us to invest in as a society because of the economic and the social consequences. Why are we able to even though we're not exactly where we need to be yet in opioids, but we're about ready to make this a national emergency. And why have we not in obesity been able to create that same kind of focus? A lot's been done. Michelle Obama did the childhood obesity, all those issues, but we still hasn't gotten traction. We don't have enough information. What is it that stops us from having that national resoluteness to deal with this?
I don't think anything should stop us from doing that, either nationally or globally. I think that when you look at this as a driver of mortality, morbidity, cost in the healthcare system, pain and suffering, in that this should be a call to arms for everybody. And I think that perhaps it's been of insidious onset. It's something that's been occurring over too long of a period of time for us to notice it, but that shouldn't be an excuse for inaction. We need to have a call to arms. And what Michelle Obama was doing in terms of increasing physical activity, that's half of the equation. We need to do that. And we also need to, address diet. And the fact that we don't have huge calorie needs with the kind of lifestyle that we live. And this is a problem throughout the world now with sedentary lifestyles and urban living. We need to get ourselves out there and be more active, and we also, unfortunately, have to eat a little less.
So, Francis, I think, as you know, this year at the Milken Institute, across all of our centers around the world, we've been focused on the issue of building meaningful lives. 1 in 5 or 1 in 6 American men have dropped out of the workforce. They're not even trying to get a job. More than half of those are on some type of pharmaceutical, and then 2/3 of those are on an opioid today. And so this is a significant challenge, and one of the things to tie in to Bob's call to action, a large percentage of those are overweight or obese. So you see this correlation between all issues today. How do you see this problem, which we're going to address today and focus on in different ways? How are you seeing it from the NIH?
Well, if I have slide 31, it shows you dramatically what's happened in this country in terms of overdose death rates from opioids in the space of less than 20 years. And you can see in that diagram of what's happened in 2015 that this is an epidemic that basically spares very little of the country, maybe a little bit less in the Mississippi River Valley, but look at Appalachia, look at the Southwest. As you all have seen those statistics, more people dying now from opioid overdoses than died of HIV/AIDS at the peak of that epidemic in the late 1980s, when the whole world, certainly our world, was focused on that. And yet here, this has crept up on us. More people dying of opioid overdoses than of car accidents. And what are we doing about this? Clearly, this is a circumstance that had its origins in some very unfortunate decisions that were made back in the late 1990s, where it was considered that as if somebody was actually having actual chronic pain, that they couldn't become addicted to opioids. That turned out to be deadly wrong. 80% of the people who are addicted to opioids, and that's 2 million people right now, started out on prescription opioids, and then gradually, as their needs increased, as they rewired their brain from the exposure to these agonists, to the mu opioid receptor, required higher and higher doses. Heroin became cheap. Many of them shifted over to injecting. Now we have fentanyl in the heroin supply, or carfentanil, which are incredibly potent, and people are dying around us. 10% of babies in newborn ICUs across this country are already addicted at birth because of their mother's addiction. And as you mentioned, the impact on human capital, that many employers can't find people to hire because they don't pass the drug test anymore. This has got to be an all-hands-on-deck moment if there ever was one. And yet, it's a very tough problem to try to deal with. We know from research that, in fact, there are treatment programs for addiction that work, but they require medication. Treatment programs that don't include medication assistance generally have relapse rates that approach 100%. And yet, the people who are looking for treatments currently have trouble finding them, and oftentimes they're not evidence-based. We don't even know how long you need to stay in a treatment program in order to be able to withdraw gradually from what that is, whether it's buprenorphine or methadone or naltrexone, in order to then have a low relapse rate. So we do need to bring together all of the capabilities of the public health system, of state governments, of state public health organizations, of research. And I'm spending a lot of my time on this and have been so since last spring. We now have 33 companies that have agreed to participate with NIH and FDA in a focused effort on how to come up with better medication-assisted treatments for addicts, better means of treating overdose, and maybe in the long run, even more importantly, the development of effective, potent, non-addictive pain medicines so that those 25 million Americans that are already suffering chronic pain every day have some other option than this dangerous one. As you can see in this diagram, all three of those areas need attention. But boy, we've got to roll up our sleeves and make this happen, because the threat to our nation is crept up on us in a way that I think nobody saw a few years ago. And now we really have, everybody in this room has got to figure out a way to help out with this situation. And my hat is off to the way in which companies have stepped forward, recognizing they've got a really important role to play here as well.
So in closing, we have brought the most diverse group possible together today. As Ed Greising pointed out earlier, between 30 or 40 states are represented. Almost every branch of our government is represented. And the largest companies in the world are here, and many of the smaller technology companies changing the world are here with us today. Academic research centers, the leaders in nutrition, schools of public health. So Bob, I'd like to start with you, maybe for a short comment and go with everyone. What can people in the room do to help you? And second, what should they be thinking about today as they interact with other senior leaders throughout the rest of the day? What would you stress here if we're going to create this new world of collaboration?
I just believe we have to raise the level of intensity and urgency. I think that we're doing a great disservice to our kids and our grandkids if we don't recognize how fundamental the crisis is in dealing with these health issues we're talking about. We will not have the standard of living for our children, even our parents today, if we don't deal with these issues. So I think that we have to break down the barriers. We have to be willing to recognize that we don't all have the solution. We all have to give and compromise and deal how we're going to make things better, and we've got to work better together, raise the level of intensity and urgency, be willing to set more aspirational goals for the things we seek to achieve, and make them more public and put them out there, and at least we know what we're striving to do. And if we don't make it, that's great. We've got to make progress, but we don't have aspirational goals, we'll not produce solutions.
Lynn?
You put up slide 26. We have a healthcare system that has failed to prevent the worst consequences of many of the things that we know how to prevent, and yet we spend more and more of a fraction of our budget every year on healthcare programs. We can't treat ourselves out of this problem. We need to turn our focus to prevention. And the only way that we can do that is if we all work together, meaning from the basic sciences, the research that they do at NIH, but all the way to the delivery of prevention services. That sometimes the hardest thing is that very last mile, getting the treatment to the opiate addict, helping people lose weight who are obese. And all of us have a role to play. You have a role to play in the business that you do. In my business as a school, we designed our school around encouraging activity. Staircases in the middle of the school instead of back in a corner. Everything that you can do to encourage your employees to walk, to encourage good diet, as they're doing at Celgene. Each one of us in our lives can make an impact on our communities. The fact that we can easily walk around Washington, D.C. and get exercise, it's because the community, and like many of your communities, has made a decision to be walkable and to make the investments in activity for all the people that live here. So we each have a role to play, but we're going to need to do that together.
So I want to thank you. Lynn, we should invite everyone to come visit you just a few blocks away, but just the idea that these floating staircases, which run 7 or 8 stories if I go down, are in the middle of the building, not in the corners, easy to take, and you have to go find the elevators. There's an entire new concept, but by building your structures that encourage exercise and encourage interaction, you can start there. Francis, what can we do to help you, and what would you recommend people to do during the day today?
Well, the good news is, while we are facing these enormous public health challenges, we're at a point where the scientific enterprise is full of potential and full of opportunity to make new discoveries that are going to change the landscape in fundamentally positive ways. But that's only going to happen if, A, we have the resources that we need to put into it and that we all work together. With the resource area, thanks to Congress, over the last couple of years, we've turned a corner from what was a pretty scary slide downward in terms of government support of biomedical research, which is the way in which the great research that goes on in our universities and institutes across this country gets supported. But we still got a long way to go. We're about 20% down in purchasing power compared to where we were in 2003. We've got to fix that because we have a lot of talent that is not being put to work the way it could. But we also have to keep looking for these areas where we can break some rules here or break some China and figure out how to work together in a fashion that traditionally there have been those boundaries. I'm all about that. I know Bob is all about that. I think we have a good attitude about that, but we got to seek for those specific opportunities and then implement them.
And I just want to stress in closing, Bob, Lynn, Francis, thank you, that this enormous explosion in cost to deal with chronic disease, which we know where it occurs from, has taken away many of our best researchers and funds from where we could have spent them on solving life-threatening diseases. And so there's kind of a double effect here. So thank you for joining us this morning, and we look forward to seeing you in the future. Thank you. Thank you.